Welcome. In this clinical masterclass, we are diving deep into substance misuse. This is an absolutely critical issue that really touches every single corner of healthcare. From the emergency room to a family doctor's office, having a solid understanding of this topic is just essential for anyone in the medical field. So let's get right into it.
So, here's our game plan for today. We're going to start by defining what addiction actually is from a scientific point of view. Then we'll look at the risks involved and how we classify these disorders. After that, we're going to jump into two really detailed clinical cases, one on alcohol and one on opioids, so you can see how all this theory applies in the real world. And we'll wrap things up with a look at stimulants and some of the broader harms. All right, let's dive into our first section. To really get a handle on substance misuse, we have to start with a clear clinical definition of addiction. You see, understanding the why behind it all is the foundation for everything that's going to follow. Okay, so at its very core, the clinical definition of addiction really revolves around two critical elements: a loss of control over using a substance and the harm that results from it. It's a really crucial distinction to make. The focus is on the individual's relationship with the substance, not on the substance itself. Now, this next point is so important to understand. There's this persistent and honestly damaging stigma that addiction is some kind of moral failing or just a simple lack of willpower. But clinically and scientifically, that's just fundamentally wrong. What it is a physiological disease. We now understand that it involves real, tangible, measurable changes in the brain's actual structure and function. Thinking of it as a medical issue is absolutely essential if we're going to provide effective, empathetic care and move past those outdated, harmful stereotypes. This right here perfectly illustrates the cycle of tolerance, and it really explains why it's so incredibly hard to quit. Let's walk through it. First, you have the cause. A substance makes the brain release an unnaturally high amount of dopamine, the feel-good chemical. So in response, and this is the mechanism, the brain tries to protect itself. It adapts by reducing its own sensitivity. It literally starts removing its own dopamine receptors. The result of that, the consequence, is tolerance. The person now needs more of the substance just to feel the same effect, or even just to feel normal. And that creates this dangerous, escalating cycle of use. Okay, so now that we've got a handle on the what and the why, let's move on to the who and the how. Who is most at risk for developing an addiction, and how do we as clinicians formally classify these pretty complex conditions? Well, addiction risk is like a complex puzzle with pieces coming from three main areas. First up, you've got biological factors. Things like genetic predispositions and even physiological vulnerabilities can play a huge role. Second, there are the psychosocial factors. These are critical. We're talking about certain personality traits and also coexisting conditions, what we call psychopathology, like anxiety or depression. And finally, you have contextual factors. This just means a person's family, their peer group, and their wider social and cultural environment. All of these things contribute to their overall risk. To navigate all of this complexity, clinicians use systems like the ICD-10. As you can see in this table, it works on two axes. That first column details the pattern of use. It could be anything from acute intoxication all the way to a full dependent syndrome. The second column specifies the substance, with unique codes like F11 for opioids or F14 for cocaine. This whole framework lets us make a really precise and standardized diagnosis. So a clinician can specify if a patient presents with, say, a dependent syndrome specifically due to opioids. All right, let's put some of this theory into practice. We're moving into our first clinical case now. We're going to apply these principles to a scenario you would see all the time in any emergency department: alcohol misuse. So meet our patient. He's a 62-year-old man, and he's in the ED, intoxicated after a fall. The thing is, this isn't the first time this has happened, and his blood tests are already showing signs of liver damage. You're the psychiatric liaison on call, and you've been asked to assess him. A really thorough assessment here is absolutely crucial. You'd start with a detailed history of his drinking patterns, any treatments he's had before, that kind of thing. Then we use specific tools, things like the audit questionnaire for screening, a breathalyzer for his current level of intoxication, and blood tests to check for markers like gamma-GT, which can indicate heavy drinking. It's also key to understand the consumption guidelines. A binge, for instance, is defined as having more than 6 units in a single session. And if you need to be precise, we use that formula you see at the bottom: the milliliters of the drink times its percentage, all divided by 1,000. So unfortunately, our patient actually leaves before he's fully assessed. But then, under pressure from his family, he stops drinking completely, just cold turkey. The very next day, he's back, and the situation has changed dramatically. He's agitated, sweating like crazy, and has a coarse tremor. So, what is going on here? This is a classic textbook presentation of alcohol withdrawal. And let me be clear, this is a medical emergency. When you abruptly take away alcohol, the brain, which has adapted to its depressant effects, becomes dangerously hyperexcitable. This timeline shows how it goes. Symptoms like tremor and agitation usually start within 4 to 12 hours. They tend to peak in severity around the 48-hour mark, and the whole acute phase can last up to 5 days.
And here's exactly why that hyperexcitability is so dangerous. There are two major life-threatening complications to worry about. First, withdrawal seizures. These happen in up to 15% of cases. And second, delirium tremens, or the DTs. This happens in about 5% of patients, and it is a terrifying state of fluctuating confusion, vivid hallucinations, paranoia, and a dangerously high body temperature. Even with modern medicine, the DTs still carry a mortality rate of around 10%. It's incredibly serious.
So, the risk of these complications is what determines where we manage the patient. On the left, you can see the criteria for inpatient care. This is for patients who are at high risk of seizures or DTs, or maybe they just have poor social support. On the right, we've got the criteria for outpatient management, which can be an option for people with a less complicated history and a stable home life. Now, the cornerstone of pharmacological treatment is twofold. First, we use a benzodiazepine, which is a class of sedative drugs. The most common one is chlordiazepoxide. Its job is to calm down that overexcited central nervous system and prevent seizures. We usually give it in a dose that reduces over 5 to 7 days. Second, and just as vital, is thiamine, or vitamin B1. This is given by injection first, then orally, to prevent a really devastating neurological condition. And this is that condition, broken down into its 2 stages. Wernicke's encephalopathy is the acute, treatable phase. It presents with a classic triad: disorientation, weird eye movements, and unsteadiness. It is a true medical emergency that needs immediate, high-dose thiamine, because if it's left untreated, it can lead to Korsakoff syndrome, a chronic and largely irreversible condition. This is characterized by severe memory loss and something called confabulation, where the brain just makes up false memories to fill in the gaps. Okay, let's switch gears and move to our second clinical case. We're shifting our focus now to opioids, and we're going to look at the extra layer of complexity that comes with co-use of benzodiazepines, or BZDs, that class of sedatives we just mentioned. So here's our new patient, a young man who comes to an addiction clinic. He reports using heroin and something he calls Tranax, which is a street name for an illicit type of benzodiazepine. Now, this combination of 2 different depressant drugs is particularly dangerous. Okay, let's do a quick profile of heroin. The desired effects are things like euphoria and sedation, but it also causes dangerous side effects, like dangerously slow breathing. The classic signs of an overdose are loss of consciousness, severe respiratory depression, and those characteristic pinpoint pupils. This is a medical emergency that can be reversed with naloxone. Injecting the drug brings its own whole set of risks, like infections and blood-borne viruses. And while heroin withdrawal isn't typically life-threatening in the same way alcohol withdrawal can be, it is intensely unpleasant, with symptoms like cramps, sweating, and goosebumps. For opioid dependence, opioid substitution therapy is really the standard of care. This slide contrasts the 2 main options. On the left, you have methadone. It's a full agonist, which means it fully activates the opioid receptors. It's very effective, but because of that, it has a high overdose risk, so you have to start low and titrate the dose very carefully. On the right, you have buprenorphine. It's a partial agonist. It only partially activates those receptors, which creates a ceiling effect that lowers the overdose risk. But, and this is a big but, it has a very high binding affinity. That means it can actually kick heroin off the receptors and cause withdrawal if it's not given correctly. All right, for our final section, let's just broaden our view a little bit. Opioids and alcohol are obviously huge players, but it's really important to have an awareness of other substances, like stimulants. And just to take a moment to summarize the overarching harms. This slide shows 2 pretty common stimulants. On the left, you've got crack cocaine, which is known for that rapid, incredibly intense high and the severe crash that follows. Then on the right is MDMA, or ecstasy, which has a mix of stimulant and hallucinogenic properties. You know, managing these and really all forms of substance misuse demands a deep understanding of everything we've talked about today, from the neurobiology of addiction right to the front lines of clinical care.
Hopefully, this explainer has given you that foundational knowledge. The ongoing challenge for all of us is to apply that knowledge to create a more effective and a more compassionate system for absolutely everyone affected. Thank you for watching.